meeting for the Medical Staff Association at Hamilton Health Sciences. The 2-hour meeting we have scheduled for you will be recorded. If there's a problem, please let us know so we can try to address that. But we hope to record this so others who can't be at this session right now can view it at a later time. There are some quick housekeeping rules we'd like to just talk about quickly. First of all, attendees, please make sure you're muted so that we can make sure that the speakers who are trying to convey some news, etc., can do so clearly. And any questions and answers you have, we'll review at the end of the presentations. Mr. McIsaac, our CEO, will be doing his session fairly early on, and because he has to leave for another engagement, we will try to see if we can organize that question and answer after his session. Other than that, if there are any issues, any things that we can address for you, any celebrations and awards and things of this sort, you have anything, questions you have, please do put them in the chat so that we can pay attention to that towards the end of our session. I think we do have one question here. Are we auto-muted already? Evelina, would you be so kind? Okay, thank you. So we'd like to, first of all, this is a quick view of the agenda. There's a good bit of stuff for the next 2 hours, as you can see, but hopefully we'll get through those with lots of interest being shown by the participants as we move along. Next slide, please. We'd like to acknowledge that we're privileged to provide care on lands that Indigenous peoples have called home for thousands of years. We recognize and respect the presence and stewardship of all Indigenous peoples as keepers of this land. Thank you. Next slide. I'd like to introduce you briefly to the MSA Executive Committee. So Dr. Catherine Ross is our past president, our immediate past president. Dr. Bill Rostevsky is our secretary treasurer. And maybe I'll ask Bill to say a couple of words about himself in a minute. And Dr. Thomas Van Helder is the vice president. And he as well might want to quickly introduce himself. And then can we just go back to the last slide, please? And maybe I can ask Bill first and then Thomas to introduce themselves, and I'll say a few words.
Thanks very much, Deepak. Bill Rostevsky. I work at the Hamilton Health Sciences, mainly at the general site as an orthopedic surgeon in upper extremity and trauma, and happy to be a part of the MSA.
Thomas?
Yes, I'm an anesthetist. I work at all three sites, but predominantly at Juravinsky and at Hamilton General. And I'm on MSA for several years now, and currently I'm vice president now.
Excellent, thank you. My name is Deepak Dath, and I'm the current president, having been at the MSA for the last 6 years. And I hope to help the MSA on its trajectory that's been begun that's been going for the last 6 years, as far as I know, and I'm sure it was going on quite a trajectory before that too. I'm a surgeon at the Juravinsky Hospital. I do laparoscopic liver and pancreas surgery there, and at the Cancer Center. And my other interests include medical education. Next slide, please. There are other members of the MSA executive as well. So Dr. Amna Ahmed, Dr. James Bain, Dr. Sarah Burrow, Dr. Peter Darby, Dr. Andrews Freitag, Dr. Alison Grice from West Lincoln, Dr. Smita Halder, who's the MAC chair, Dr. Derek Hunt, a previous past president, Dr. John Myrna, another past president, Dr. Paul Masuna, Dr. Ted Rapanos, Dr. Chris Ritchie, 3 presidents ago, Dr. Sanjay Sharma, Dr. Catherine Zukatinsky, and Dr. And then Evelina Grisavi. Evelina, as you know, is our admin, and she is the one who is responsible for all the greatness of the MSA. All the things we do really rest on her shoulders. She's been doing a great job of helping us move along and change some of the ways we work at the MSA. So thank you very much, Evelina. And as well, we'd like to welcome our HHS executives. I believe Dave Lazzarato is not on the call today, on the meeting today, because he had another appointment at the same time and couldn't get away from that. And I think Sharon Pearsons as well was not here for a similar reason. But we do have Dr. Michael Stacey and Mr. Rob McIsaac, who's our president and CEO, and we will hear from both of them over the course of this meeting. So first of all, to congratulate Mr. Dave Lazzarato, who's just stepped into his role as the new HHS board chair. I've had the pleasure of meeting Mr. Lazzarato several times in the previous year, and then being part of the meetings of the board where he's chaired, and I have a great deal of respect for what he's doing there. We'd also like to thank Mr. Charles Cremonesi, who stepped down from his leadership role as the board chair before Mr. Lazzarato stepped up. Next slide, please. We'd also like to welcome Sharon Pearsons in her new role as EVP Clinical and COO, replacing Dr. Wes Stevens, who held that role and was a leader in that area up until that time. Without further ado, perhaps I'll ask Mr. McIsaac to step in and say a few words to us and give his presentation.
Yeah, thanks very much, Deepak, and it was very gracious of you to recognize both our our past chair rather, and our new ish chair. I think HHS has been really blessed with very high quality, talented chairs for which I'm really grateful, because it makes a big difference for me. Also, of course, thanks to the MSA and the MSA executive more particularly for your ongoing leadership and collaboration. I'm really looking forward to opportunities in the relatively near future to connect in person with physicians from across HHS. While Zoom is an amazing platform and has enabled a lot of dialogue across the whole of the pandemic. Really, there's no substitute for face-to-face gatherings. So I am making a deliberate effort to get out to all of our sites in the coming days, and that'll be an opportunity for me to hear from the front line, on their reflections on our work over the past 20 months and longer, and where we're headed going forward. It is hard to believe that next month marks 2 years since the first outbreak was reported in Wuhan. I was saying the other day, I've been in Wuhan a couple of times, so it's a kind of strange feeling to know that I was there at the very place where this unbelievably disruptive period started. It wouldn't really recommend it as a tourist destination. We've been through so much since then as a community, as a hospital, and as a team. And I imagine that for some of you, it's been perhaps one of the most trying times of your career. And I can certainly relate to that. Beyond the professional challenges, there have been personal tolls and sacrifices. I was saying the other day at a leadership meeting, as difficult as it's been, I don't think I would have wanted it any other way. We're not the first generation to have experienced an epic struggle like this. They weren't all the same. But when you look back and you think about the people who got involved in those struggles, at least for me, I always would have wanted to have been one of those people. And so as difficult as the last 20 months has been, I do take some pride in having been part of the struggle against this pandemic. And I do think for all of us who've been involved, it's a kind of a link that we share with each other. But on behalf of HHS leadership, I'm really very grateful to all of you for your ongoing dedication throughout this most challenging period to our patients and our community. Next slide, please. So COVID hasn't gone away, but I think my conclusion from the current state, although we saw a little bit of a spike today in the numbers, is that managing COVID will be one of our priorities going forward, as opposed to, the overwhelming priority. Of course, we are thinking lots about recovering from and managing COVID as an endemic virus, as opposed to something that's completely dominant on the scene. This work includes focusing on trying to create capacity for surgeries and procedures that were delayed during the pandemic, and continuing to address the longstanding challenges of attracting and retaining top quality healthcare professionals. We know that our entire health and social services system has been strained. Many of the minor fault lines that were evident prior to the pandemic have become big cracks in the system today, and will be a big area of focus in the coming days and weeks and months as we move into this sort of recovery phase. I think it's really also super important that we continue with the innovative changes that were spawned by the pandemic, which benefited people, both providers and patients, and created new pathways for healthcare going forward. Next slide, please. We continue to work to implement mandatory vaccines at HHS. My strongly held view is that as the largest employer in Hamilton, we need to be a role model and demonstrate leadership in our community. That said, it's been a very difficult road to hoe, and it's been very polarizing, both within HHS and within the community. But for me, this is about the safety and well-being of patients and everyone else at our sites, and it's about ultimately it's about the well-being of our community. As of November 16, more than 95% of HHS staff and physicians are fully vaccinated. The overwhelming majority of physicians are fully vaccinated. And I think that that's such a great leadership position for our physician group to be in, that it's really less than a handful of physicians that have yet to be vaccinated. And so I'm super proud of that. Our goal remains to achieve 100% vaccination rate for hospital staff and physicians. Of course, there'll be some limited human rights exemptions grounded in medical or religious reasons. More people are choosing to be vaccinated. In fact, nearly 600 HHS workers have chosen to get their vaccine and remain with our organization since our policy was announced. So I think that's good progress. We're undertaking this work in collaboration with hospitals across our region and moving forward in a reasonably consistent manner so that patients, staff, and physicians can know what to expect. Next slide, please. Thought it might be interesting or helpful, to provide a brief update on a few key projects underway at HHS. Of course, the big gorilla in the room is Project Odyssey, and it's moving steadily towards its go live date in June of 2022. I think you're going to hear more about it later in this meeting. I just wanted to acknowledge the ongoing work to prepare our team for the installation of Epic, our new HIS, next June, and say thanks to all of those who've been engaging in this work to date, particularly Rob Lloyd and Barry Lum for their leadership and for ensuring almost everybody is informed and engaged as planning continues. Implementing Epic is a really critical step in modernizing our hospital and further enhancing the safety and quality of care, and a key priority for HHS. I think our physician group understands that better than anyone. As an academic health sciences center, we allowed ourselves to get behind And this is absolutely critical for us to maintain our credibility as one of Canada's top academic health sciences centers. While the pandemic has impacted every aspect of our work at HHS, our team has remained on track impressively and continues to achieve key milestones. This is such a tribute to everybody on the team for their focus, not only on patient care day to day, but on the future of patient care at HHS. I think you all know EPIC will transform how we work as a team to deliver safe patient care. It's going to help us to collaborate, integrate, innovate better than we ever have before. It'll also help us to integrate solutions at an enterprise level so that we can truly have an HHS way of doing things. Really exciting and important work. And I know that we've got the best team in place to lead us through the next 7 months and beyond. I think one of the things that medical staff can do is to share their excitement with our teams. I think for those of us, and I would include every single physician in the organization as a leader, showing optimism and confidence will really inspire engagement on the rest of the team. I did want to talk a little bit about health human resources. It goes without saying that all of the work we do requires ongoing monitoring and managing of our most important resource, our health human resources. And we know that there are significant challenges in recruiting and retaining staff in this environment. It's not unique to HHS or even to our province. It's in fact a worldwide issue. Demand is outpacing supply in a number of really critical designations, although it feels like almost every hire is more difficult than it used to be. But particularly nursing and key technologists and technician positions. We've been working on a number of strategies. It's really our one of our most significant priorities, along with Odyssey, to try to make sure that we're out there recruiting as effectively as we can, as well as working with valued staff here to make sure they feel respected. Some of this work has really been complicated and impacted by the pandemic, and our HR team continues to work really hard to support our response to help us to attract the best and the brightest. I also thought I'd mention, our work to attract great talent doesn't just rest with those who are recruiting. It's a responsibility that in some respects rests with all of us and includes fostering a culture where everybody feels welcome and respected. I wanted to say thanks to Michael Stacy and to Smita Halder for their leadership in advancing positions and processes that will help us evolve our culture and our ways of working together as we move forward. The President's Equity, Diversity and Inclusion Task Force is in the process of developing recommendations, which will be in part based on input from our workforce gathered through various mechanisms. I hope you'll take some time to respond to the survey that is coming forth imminently, provide your input to help inform this work that we're doing. It's really important for the health of our workforce and our patients and families. So for all those who are involved in that, thanks for your leadership. Next slide, please. Just a couple of pride points that I wanted to mention. First of all, congratulations to everybody who was involved in supporting our team to become a level 1 Choosing Wisely hospital. This fits so nicely with our work to implement EPIC across HHS in June. It's going to help our team ensure we are performing the right tests and treatments at the right time. It's another, I think, really tangible demonstration of our commitment to high quality, more sustainable care and excellence in patient experience. Maybe I could also just mention, significantly, we recently resumed obstetrical services at West Lincoln Memorial Hospital with the hiring of Dr. Mosher. West Lincoln's newest obstetrician and gynecologist. Our team also significantly remains on track with the work of planning for a new West Lincoln Memorial Hospital, even amidst the challenges of the pandemic, which is a true testament to the focus and dedication of all of those people. Next slide, please. So I'm super grateful to all of our partners who've worked with us for the past 20 months. That includes the local, provincial, federal governments. Our team is already turning our thoughts to planning for the next fiscal year, including budget planning. In the coming months, we'll be working with leaders to develop our plans and continue to advocate for patient care needs at the province. Maybe I could just reiterate my thanks to all of you for your continued collaboration and commitment to patient care at HHS. And I think, all of us need to work together to really emerge from the pandemic, to resume and restore services across all our sites and transform care for our patients. So Deepak, thanks as always for the opportunity to say a few words, and happy to try to answer any questions.
Thank you, Rob. Those were very useful things for us all to hear. I'd like to say that in the time I've been the president for the MSA, and just a bit before that, we've had a chance to work together, you and I really appreciate that. I love to see how you and the rest of the team are leading the organization. I think we're doing very well, and as you said, we if there was a scorecard for HHS coming through the pandemic, I think we'd receive very high marks, and that's thanks to you and all of us who are working together to make this happen. I'd like to give the participants here an opportunity to perhaps ask you some questions, if you're okay with that, Rob.
Yeah, of course. I'm glad that, of course, Michael, and I see Sharon Pearson is with us as well. So that's great. If I get something wrong, I know they'll help to shore up what I say.
Welcome, Sharon.
I wonder if Sharon was designated as a panelist. Oh, there she is.
Yep.
Looks like she has not been designated, Deepak.
Alina, would you be able to change that, please, to invite Sharon to be a panelist so she can participate? Thank you.
Thank you, Deepak. I am here.
Thanks so much. So perhaps if we don't have some questions, do we have any questions in the chat right now? Evelyn, are you seeing that?
No
right
questions right now, Deepak.
Thanks, Bill. Thanks, Bill. So I wonder, maybe if you don't mind, if I can maybe throw out the first one. I guess it's been quite a while now since as you said, the overwhelming attention has been to COVID, and we have some stability. We've succeeded in trying to put processes in place to keep things fairly well in check right now. We have a workforce that is immunized to a great extent. We have some challenges such as the workforce challenges, but we still have to work on things like our Epic. And as you mentioned, there may be some other things coming down the road. I wonder whether the other projects that we have to start thinking about in the future. Just thinking, okay, fine, we've all seen enough of COVID. What are the things that the members on this call can start looking forward to over the course of the next year, Rob?
Yeah, so good question. So we have a number of transformational projects, one of which is Odyssey, but there are others as well as designated corporate projects that we have identified and we will be thinking about in the coming months and years. So I will say, I do think a lot of everything currently is on the table for consideration to be paused to ensure that Odyssey is successful. So we are going through a very deliberate exercise right now of capacity creation to ensure that people have enough time to actually do what's going to be necessary for us to have a successful go live. So if I just say that and set it aside for a moment, I think all of the rest of these things could slow down to some extent to make sure that Odyssey works. But, you know, of course, we are continuing to work on replacing all of our, virtually all of our diagnostic imaging equipment. I think within the next 3 to 4 years, we will have a virtually new fleet of diagnostic imaging equipment because of the managed equipment services contract that we'd entered into. So I think that's very good news for HHS and for our business continuity. We had developed some work around what was called our strategic partnership collaborative. Those were sort of efficiency kinds of initiatives. So there are some, while we have stood that project down, there are some legacy project things coming out of that geared towards efficiency that we will continue to work on. We want to continue to make sure that our management system is as slick as it can be, so that, you know, strategic priorities are well understood and well implemented across the organization. So that's sort of the top-down view of the management system, but also making sure the pipelines and pathways are in place so that people on the front lines can escalate issues that they're noticing that need resolution. So that CQI management system, we're now calling it operational excellence, is also a big transformational priority for us going forward. Then there's a number of corporate projects that, you know, we think are really important. We are looking at a clinical services plan. Michael and Sharon are leading that. I think really that project, once it's completed, will give us a process for, on an ongoing basis, assessing the health of all of our clinical programs, so that, you know, things we can catch if there's a problem in a program, or if the quality of a program isn't where it should be. It's something that we catch early and address. So I think that's important work. We are working at responding to the new laws surrounding MAID, making sure that HHS, which is really a leader in providing MAID for our community, has intimate connections into the community, and that, you know, we're providing that service in a way that we can be proud of. I'm just doing this off the top of my head.
Our hospice.
Right, yeah, so we are working on a pediatric hospice program with Bob Kemp Hospice, and that I think is a really inspirational project that I think has captured the community's attention. So that'll be a partnership between McMaster Children's Hospital and Bob Kemp Hospice. Of course, we also, I had already mentioned this, but and you mentioned it too, Deepak, our workforce planning is a really key project that will not be paused just because of it, how important it is for everything else.
As post-COVID recovery and the EDI work, Rob?
Yep. So I had mentioned EDI earlier on, and then I had mentioned post-COVID recovery efforts as well. So I think those are what we're seeing as the biggest priorities. I think we've gotten them all, but I've certainly addressed the lion's share of them.
Thank you. You know, we have a full slate, but I think while you and Michael and Sharon are here, perhaps I could engage the three of you with one more question. I don't see anything else in the chat here, but please, if anybody else has something to add, please do it now. But the other question I had, and this goes to how we'd like the MSA to work, is maybe a couple of thoughts from each of you, if you wouldn't mind, about how we can get the rank and file physicians at HHS. Like, what do you see us? How do you see us helping and being part of the solutions at HHS? How do you see us working with the institution better?
Yeah, I wonder if Michael might lead off as a chief medical exec.
Yeah, no, happy to. Thanks, Rob, and thanks for the question, Deepak. I think really some of the work that's been done by your predecessors, and I know that you're engaging in as well, is for the MSA to really put themselves forward to support many of the projects that are ongoing, and then to lead that into the medical staff within the organisation. And I think a good example would be the support that the medical staff has given to the Odyssey project, which we know is incorporating a lot of people in it. But to have the MSA champion that within the medical staff group, I think is a very valuable process for us. I think also, having the regular touch points of the leadership with the Medical Staff Association also helps in that dialogue, so that we're each aware of what the other's doing. So, I think that's a really important way of creating that engagement and continuing that engagement. So, but I think really having the MSA act as a champion for the new initiatives that are coming in is really a very valuable thing for us. So I'll probably leave it at that. And maybe Rob or Sharon may want to add other things.
Yeah, I could add, and I think a good example was last evening, we held a 3-hour session, facilitated session with Ernst & Young, and invited representation from across the organization, from the surgical services and those related to participate. And, those are tough sessions. They're 3 hours long. They're at the end of the day. We talk a little bit about frameworks, but I think it was really good dialogue. And it was a great opportunity for me to get that input as we think about what our surgical recovery plan would and should look like. And so, taking up the opportunities to participate in some of those sessions and let us hear directly, the concerns and the suggestions, that's invaluable to me. And, a few years ago, we had a session where we had deliberately invited, drop-in sessions, and I met physicians I had never crossed paths with, and some I still stay connected with years later. It was a great opportunity. So, look for suggestions too as to how others would like to link in and connect.
Deepak, can I guess one observation that I would make, and I said in my remarks that, some of the great things that we needed to do and got accelerated during the pandemic, I hope we can carry on with. But, my strong belief, or my observation across the whole of the pandemic, was that physicians and administrators work together in ways that they never had previously. And we saw that kind of dyad concept, that partnership between physicians and administrators, I think manifests itself more strongly during the pandemic than maybe ever before, at least in my experience. So, I hope we've established, and I'm not relying completely on this, but I hope there's some muscle memory there that we've established that will carry on post-pandemic, in addition to the the good ideas that Sharon and Michael have mentioned. I also just wanted to, I neglected to mention Dr. Sanjay Sharma, who's doing yeoman's work as well with Dr. Halder on that EDI task force. So my thanks to Dr. Sharma as well.
And Rob, maybe just to elaborate on that, that dyad or collaborative leadership model. I mean, as many of you will be aware, that was implemented a few years ago, and it really got sort of paused pretty much at the start of the pandemic. But I've just had discussions this week with our organizational development team to look at bringing that back. Probably once we've gone through the Epic installation or opening up of Epic, but definitely have plans to bring that back, to extend that collaborative leadership model further into the organization. So to have the physicians working with management more, to Rob's point, things that have developed organically through COVID, we really want to strengthen that going out of COVID as well.
Thank you all. So what I'm hearing is that from what Rob said, there's a large number of portfolios that are open for physicians to participate in as you move forward. And it sounds like Rob and Sharon and Michael are all looking forward to physicians stepping up and looking forward to what's coming up tomorrow. Not just, not just maintaining what we've done with COVID, but looking at what's coming up tomorrow and participating as a member of the HHS organization in leading some of these things, in working with our partners in nursing and in other healthcare areas, and with our exec and our administrators who help run this place. I think that's very exciting, and I've seen that the needs are aligned with the values that we all have. So administrators, non-physicians, and physicians all seem to be aligned towards patient care, high quality care, and there are things that we can now look forward to working on together. So so thank you for that. I think that puts a very positive spin on the future for us to become one entity, not us and them, but people walking together with a parallel path. And perhaps as we go forward a bit, I'll talk a bit about more of that again. Bill, any other questions that have been coming up in the chat at all?
Nope, no other questions. I think that was a crystalline tour de force of where we are from an altitude view of the HHS and where we're going. So I think it's no questions.
Okay, so maybe we'll move forward, Evelina, if you wouldn't mind advancing the slides, please. So just a quick MSA update then. So next slide. This is kind of where I think the MSA is going. This is what it feels like right now as a president of the MSA. I think, so I told you I'd tell you a bit about the presidents. And so I've seen 3 presidents and I've not seen the others before, but I'm sure they were building the plane and building the airport and smoothing the runway and everything it takes to get this plane in the air. And it feels like the MSA plane is in the air right now. That's our MSA, and you can't probably see it on the slide, but towards the tail that said that's a Dreamliner, and I put that there specifically because I think we're aiming for the skies, and we're going to achieve our dreams. We're gonna move forward pretty well here. I've seen Catherine Ross kind of help to move things together to try to maintain some of the relationships. Dr. Hunt before that was doing a lot to make sure that things like our ducks are in order, our paperwork and our the definition of what the MSA does, our bylaws, our constitutions, etc., really well. And Dr. Ritchie was actually very good at trying to improve the MSA's position in terms of its size and its ability to function. Those are just 3 things that come up, but there are many other things that I've seen happen over the course of the last 6 years. And I hope that all of you feel like you're on this plane and that we're all going through this journey together. Next slide, please. So a few things that we are trying to change at the MSA is to organize a bit of how we work. And there are 3 particular things I think over the next 2 years I'd like to try to make sure happens. The first is our relationship with HHS, and you've seen that. Right now, I think Dr. Stacy, Sharon Pearsons, and Rob McIsaac have just told you that they're looking forward to working with us. I think that builds trust, right? I know that at all institutions there's sometimes a lack of trust, or sometimes some wedges are built between are drawn between those who work here and those who help run the place. But I'm hoping that we can kind of get rid of some of those things, because I've seen that the work that they're doing is actually very productive, and that they care about what's going on here as much as anybody else. I'd like to make sure that the trust that we have as physicians with our institution and with those who help run the institution is very high. Without that, we can't do our work. Without that, they can't do their work. One of the things that comes up is, what are the kinds of things that we can do to ensure that we're colliding with the people around us more? So how can we meet the people who are non-physicians, who help run this place, who help do some of the work that make things go forward, and meeting them and working with them? How can you make the place better? So we'll try to see if we can make some of those things happen over the course of the next 2 years. So look out for activities and for particular types of deliverables that we hope will allow us to work together and cement those relationships. The second part is how we do our work. So most of that has been defined in our meetings. And at the MSA, we've had long meetings where we have long discussions about things. But one of the things that we've tried to do in the last little bit is to partition some of the work off into groups of subcommittees. And you'll see a slide that on a slide coming up. We'll talk about maybe what some of those structures are and some of the goals and outcomes of those committees, how they're going to work, and how you're going to find out what work they're doing and how you can participate in that work as well. And lastly, the kinds of things we're going to achieve. So we get to decide where this plane goes, right? We get to decide, how high up we go and whether we do loop-de-loops or where we're going. And to that extent, we have to start with maybe our top priorities. One of the ones that I think is really important is aligning ourselves with the mission, the vision, mission, and values of the hospital, and trying to make sure that we get there together. I don't know that we are going to be able to do this without that. Next slide, please. So here's a list of some of our current activities. The document subcommittee, which is being led by our past president, one of our past presidents, Dr. Derek Hunt, is refreshing the MSA Constitution and the vision, mission, values. We've already gone through this, and what I hope is that we will be able to present to the members, that those of you who are there, and perhaps if you wouldn't mind, tap your friends on the shoulder and let them know that this is something important that they might want to participate in as well. But looking at what our vision, mission, and values might be and how they align with what the hospitals is, because I don't think we can be proud to work here and be going in two different directions. So that's something that I think we should make sure we're doing really well. Derek's leading that with others, and we'll leave that till later to come back to you with that. So Michael was part of the physician hospital partnership a while ago, and I know that there was a civility group looking at some things. I think it got parked just before the pandemic, but I remember, and Dr. Ross actually has been active in this. I remember the civility program putting out the STAR postcards that we can send out to the people who work with us. And I think we should reinvigorate that campaign. So we're going to start a thank you campaign. And that's something we're working right now. So look forward to that in December, the thank you campaign, where we can get the medical staff, those of you who are here and your friends, to start saying thank you to those we work with and those who really help make this place run. There's a survey that Dr. Catherine Ross has also been working on with St. Joe's to try to look at what it is that we do right now. What are some of the stress points that we encounter? What are the things that cause us sometimes to feel that stress and the burnout, and how we can find ways to ameliorate that? I know that's a very important thing on the horizon for the institution as well, to make sure that those who work here are well, including physicians. And there's a wellness program in place for that. So we'll try to see how this survey can help inform that. We've worked on the COVID-19 vaccination mandate, trying to see what your ideas were about this, how you felt about it, and what you needed to do to support the hospital as it went through this process of determining what our policies are. And then, of course, there's incident management, which is what I call the physician complaint process, because I don't think all these things are necessary complaints. Of course, there are things where things don't go completely right all the time, but we should be able to manage some of those incidents, and the MSA does play a big role in that. It's always been one of the key components of what the MSA has been doing to support our fellow members. It will go forward, but hopefully we can work with the hospital to improve that as we go forward as well. Next slide, please. So this is what our website used to look like up till just recently. We were starting off, and we put something in place so that we could collaborate, so we could find a place where all our information was, so we can send people to the right links, etc. But as of recently, Dr. Catherine Zukatinsky, as well as Evelina, have been creating our new MSA website. And this is more what the splash page looks like. And what I hope is that you'll be able to look at this website now and find that it's very much more organized, that it's set up in such a way that the information you need as a physician will be readily available for you. And you can search these areas, you can look at things that have happened in the past, you can see what's coming up down the road, and you can try to reach out to us as well as to participate. And how do we do our work? Well, meetings, I think, are going to help us achieve some of these things. And we've reorganized our meetings, as you've heard just now. We'll have deliverables. We'll have things where we follow through to make sure that our decisions that we have around the MSA executive table will reach the fruition that we expect. We hope to have better engagement. As of right now, we have 7 subcommittees, and in those subcommittees are going to be people who can participate in the MSA, not necessarily as MSA exec, but perhaps with an eye to looking at being on the MSA exec and participating in what really happens here at HHS. We'll try to improve our communication to you, try to make sure we're listening to you better, and we'll try to make sure we're celebrating the things that happen at HHS. So relationship building, there are many ways that we can reach out to entities at HHS in the exec. You can see some of them here. The board of directors, we have a non-voting seat on the board of directors. So if there are things that the physicians need to have seen at the board level, we can do that. We are part of the Council of Chiefs. We're part of the MSC, the Medical Advisory Council. We are tied into the communication process in this hospital, and they're helping us to make sure our communications aligned with theirs as well. We are separate but parallel. We do have a strong line to the Medical Affairs credentials process and the Office of the HHS President and CEO as well. And of course, as you can see here on our screen, we have the ears and we have the thoughts of the EVP and the academic and CME members as well. So we are tied in. We are tied into this hospital very strongly as the MSA, and with 1,000+ physicians, that's a really, really strong group of people who have capacities and who have the intent to do good things and who can participate in how this hospital gets better tomorrow. These are some of the subcommittees. I'll quickly go over them. The document review committee by Dr. Hunt is charged with looking what our constitution looks like, what our vision, mission, values looks like, our corporate and professional bylaws and other documents that we have, the things that we stand by, the things that document what we stand for. MSA recruitment is a new one. Dr. Ahmed's here. I saw her on the screen somewhere, and she's in charge of MSA recruitment, succession planning, and physician onboarding, so that when new physicians come onto HHS, they see this as a great place to work, and they know who's here. They perhaps can be mentored with somebody else if that's something they'd like to do. Dr. Ross has agreed to take on physician education, and I know she has some ideas, and perhaps maybe she can talk to you about that in a bit, about how we can engage together to learn together and to become better at what we do, not just in terms of knowing what appendicitis is or how to fix potassiums, but the things that help us to do our work. Dr. Sharma, who's working at the hospital level in EDI, is also part of our is also leading our EDI team here at the MSA, and I'm trying to help us with our communications in terms of our social media and how we communicate with our hospital and with you. Catherine Zukatinsky is our website liaison, working with Evelina to provide you a website that I think you can be proud of and that's very functional. Bill Rostevsky, who is our secretary and treasurer, will be helping to make sure that the meetings and events are running smoothly, and that we're improving what we can do that way. And as we improve these collations, I hope we'll have more of these things that Bill can help us with. And Tom Van Helder is helping us with our awards review, which is a big part of what the MSA does over the course of the year. He'll be talking to you a bit about that later. The thank you campaign, I'll just say 2 words about. So this is one of the postcards that's available on the web, on the hub, that was brought about by, I think, the civility group at PHP. And we're going to see if we can get that maybe more functional with you. So please look in December as to how we try to launch this, and please help us to make sure that we are saying thank you, that we're saying thank you and meaning it to the people who work around us every day. Those who clean the floors, those who fix our IT, those who those who help our patients into the rooms, those who take people around and make sure that the things that you reach for are on the shelves. Everybody who works here needs a thank you. They're all coming to work, and they all came and kept us going through 2 years of pandemic. I think it's time for us to be more prolific in how we say thank you to them. Next slide, please. This one is a quick public service announcement. So the flu shot clinics are happening, and they are at all the different sites. You can see here that there are particular times that they're open at these particular sites, and we do hope that you take the time and take it seriously to get your flu shot as well. I know not everyone can get it exactly at the same time, but please do see if you can get there as soon as you can, and make sure that you're vaccinated, not just against COVID, but against the flu. It has its own problems as well. All right. And lastly, another service announcement is the booster eligibility for healthcare workers. So those of you who received your vaccine a while ago may now be eligible to receive your boosters, and the vaccination clinics can do that. They've been able to do that since the 8th of November. So if you go to the website that's on this slide, and it'll be on the website as well, on our MSA website, you can check the MSA website and find out how you can book your appointment for your booster COVID shot. And then perhaps what I'll do is maybe turn this over to Bill Rostevsky for our review of the financials.
Thanks very much, Deepak. Not much has changed on our financial sheets, except for the fact that our live events weren't happening during COVID, obviously. So we're a little bit more in the black than we would normally be. So we perhaps have a tiny bit more funding available to help out with some of our ongoing projects. Next slide. This just shows our major expenses in color code, with things being like stipends, donations, and the general business meetings leading the top three. There looks like there's a bit of fluctuations, but that's mainly how the finances fell into the grouping of the actual fiscal year. Some of the high spikes should have happened in the year before, but when they got paid out, it happened in the next fiscal year. So it just shows up like that. So the average, the averages have remained the same. And that's about it.
Thanks, Bill. Perhaps we can ask Thomas to take us through his section.
So as you can see on the slide, there are several awards that we present usually in our winter meeting of the general MSA meeting. And I have a couple of thoughts about these things. Perhaps I'll start with the last point, which is the charitable donations. There is typically, well, there's a call for charitable donations. They are each, we award typically two, they are each $5,000. So monies that are raised from the fees for the membership fees for the MSA. And often we receive several nominations for different local charities, and at one or two occasions we actually couldn't quite decide which charity is more suitable, so we split the difference and gave the 3 donations instead of 2. And so I'm not promising this year, and of course it depends on our finances. But I would like to call for the nominations, nomination letters for the favorite community organization that could do with $5,000 donation from the MSA. These all these nominations that I'm going to talk about are due on January 7th, which is a Friday, and we should have enough time to think about selection and present it at our winter meeting, which I think is also in January. Then starting backwards, so there is a community action award, which is somewhat similar to, well, it's not for the charity, but it ties with it. And this particular award is a new award. It celebrates, it's designed to celebrate or highlight someone or some physicians or work these physicians do to reach outside of the HHS and be involved with the community work. And the physicians, the call for the nomination, ask for physicians to be nominated for this award who would typically act to help vulnerable, marginalized, underserviced, or racialized members of the community. And the recipient of this award should be somebody who has a track record this, I don't know, a service to the community. So that's the Community Action Award. Then there is the Family Medicine Award, which is calling to nominate a family physician who is associated with HHS and who exemplifies the excellence in care and who strengthens the relationship between the community practice and the hospital. And again, the deadline for this is January 7th. Then we have the West Lincoln's Colleagues Award, and 3 awards named after Dr. Clive Davis, Dr. Dan Dwyer, and Dr. Jeffrey Coates. The West Lincoln, and then all these 4 awards actually have the same criteria for the nomination. These are all available on the MSA website, and that's how you get the forms. But the criteria are that this colleague is above average clinician, is a patient's advocate, it's above average in the art of the science of medicine, and is collegial, is one who would teach you something most of the time when you interact with them, so you learn something new from these individuals, and somebody who leads or participates in hospital initiatives to improve overall patient care. So these 4 awards are the same awards criteria. The one thought I have is about the names for these awards, and we had many discussions over the last couple of years at the MSA, whether the awards should be named after specific physicians or whether they should be more generic, such as the West Lincoln's Colleagues Award. And we never actually settled this question, and I would like to ask the MSA members to express their opinion on how they feel about it. On one hand, it's always very important to acknowledge exemplary physicians who worked at the HHS. But on the other hand, the time doesn't stay still, and there are other physicians who are just as exemplary, and maybe they should be recognized. So some of the organizations, they have a time limit, several years on the name of each award, and then it moves on to someone else. So I would like to seek some input from the members of the MSA, because these awards are awarded to physicians on behalf of the MSA, so it belongs to all of us. It doesn't belong to the MSA Executive Committee, and we will see where the feelings are regarding the names for these awards and how they should be recognized. So I would ask everyone who would like to express their opinion to let us know what would be, in their view, the best way to proceed. So again, all these awards and the one for the charitable donations, the deadline is January 7th, and we are looking forward to this.
Bill and Thomas, thank you both for that update. I'd like to echo the fact that that we really do want some guidance from the MSA members themselves about these awards. It'd be really nice to be able to hear some ideas or kind of really how you feel about that. And perhaps, Thomas, we might be able to reach out specifically to find out with a survey or something. One of our one question surveys, maybe that's the next one we should do.
Yes.
I'd like to, we're just getting a bit late, so I'd like to move on before we get too late to Dr. Michael Stacey, who prepared a few words for us, and perhaps we can hear what he has to bring to the MSA.
Great, thanks.
Thank you.
Great, thanks very much, Deepak, and thanks for the opportunity to speak this evening. What I'm going to do is just to update you on some of the activities and functions that are happening within medical affairs. And I'll try and be relatively brief. So the first one, as I think you'd already alluded to, Deepak, is the mandatory vaccination policy, which the medical affairs team and the chiefs have been working on. I think we had definitely an opportunity to celebrate that there were no physicians who had not reported their vaccine status. So that was an excellent effort by everyone to ensure that everyone at least reported it. We have a small number of physicians and some midwives who are in the professional staff category who are, at least at last count, not vaccinated. But we're working closely with each of them and trying to get to a position and a plan for each of them. I do know that some have already been vaccinated or had one dose. There's at least one has an exemption, a temporary exemption. So what we're trying to avoid is the need for anyone to have their privileges suspended, and hopefully we can get a position with each one so that we can work together to ensure that all of the physicians are able to continue working successfully within our organisation. Second issue there, the second point there is around the hospitalist model for general internal medicine and general surgery. So we know we've had some resident shortages and problems filling all of the shifts, particularly for the out of hours work. There was a program to implement some physician assistants to support those programs at the two adult sites at Hamilton Health Sciences, but also at St. Joe's. It's become apparent that we probably need a more robust and sustainable program. So currently there's work looking at creating a hospitalist model to support those programs in both internal medicine and general surgery, essentially to replace the gaps and the shortages that exist because of the resident shortages. And the resident shortages are in part because there aren't probably enough residents in the training programs, but also with the change in training, not all disciplines require the residents to do blocks in general surgery or general internal medicine. So that's caused some of the gaps. We're looking at some support for anesthesia. There's been a lot of work looking at anesthesia assistants. Again, it's a group that's relatively short in supply. So we're looking at some interim and some longer term options for supporting anesthesia, with those additional supports in the operating room. Some work that had started pre-COVID was on a new physician orientation process. And the medical affairs team is starting to dust that off and look at realigning that. And that does involve, having some physicians involved in supporting that orientation process. And so you will start to hear more about that probably early in the new year as we start to relook at that. The performance review process for site leads and service heads. So we have developed a process for performance review for chiefs, and the medical affairs team has worked on that for the site leads and service heads. That's something that, again, has been a little bit paused because of COVID, but we hope to have that able to be rolled out probably early in the new year as well. And ultimately extend that down to performance review process for all physicians. Next slide, thanks. I think you'll be aware that we've got the Senior Medical Director of Equity, Diversity and Inclusion. That's a new position that we've created for someone to sit on the MAC, to be a member of the EDI task force that's part of the initiative that the CEO has initiated. And they'll also then support the development of similar positions in each of the departments. So really creating that focus on equity, diversity and inclusion, and looking at supporting other educational supports for physicians, but also to be involved in part in recruitment, to be involved in some of the performance evaluations. So really to have that EDI lens on how we do business within the organisation. You mentioned, Deepak, the Physician Hospital Partnership, and certainly there are a number of initiatives ongoing, but one of the new ones that's just starting some work is on physician wellness. And so hopefully we'll see over this coming year, or maybe a little bit more, some initiatives come through that. I think those of you who are at the quality rounds earlier this month saw some really good presentations from Canada Zam and from Hélène Flagiol, looking at initiatives both in medicine and also in surgery. And I think for us, they're very, very key initiatives to be able to understand the quality of the work that we're providing, the care that we're providing for patients, and to try and continually monitor and improve that. Just so you're aware, there's been a lot of activity around chief searches, so a number of chiefs sort of ending or have ended their times. And so you can see there those that are current and those that will be next in the queue into next year. So really an ongoing process at looking at replacing those chiefs who've come to the ends of their terms. Next slide, thanks. And I really just wanted to highlight, just to finish off my talk, there's been a lot of work also in the organisation looking at the strategic direction and the strategic metrics as they relate to our North Star objectives. And just wanted to highlight that there have been a series of projects that have been initiated during this year that align to some of our North Star objectives. And some of them are definitely involving surgical groups. So one of the North Star objectives that in the realignment of those objectives is to be a top performing High hospital. And within that, there are two pieces of work, one on reducing sepsis and one on looking at deaths after major surgery. So Kirsten Kroll is leading the sepsis piece. Steve Kelly's leading that piece on deaths after major surgery. So looking at initiatives to try and reduce the incidence of some of those things in the organisation, and to try and align us from being outliers in those areas to being very much a leading hospital, top performing hospital. Other initiatives that relate to our North Star objectives. One is the objective of eliminating never events, and the focus there is on pressure ulcers, and looking at an initiative to reduce that. So that'll be starting quite soon. And some of that activity will be on some of the wards, not all wards, into the next year. And also some work on lost time injuries. And there has been some work on this. It'll continue, but it aligns to that North Star objective of having zero lost time injuries. So I think that's the end of my slides, Deepak. So I'll pause there. Thank you.
Sorry. Thank you, Michael. I think next we have a bit of a medical advisory committee update from Dr. Halder. If she's, I see her, she's available there. Smita would be able to help us with that.
Yeah, thank you very much. Thanks, Deepak. Next slide, please. So I thought what I'd like to do for the members of this meeting is to just really outline again what the Medical Advisory Committee is and what the functions of it are. Mainly because when maybe 2 or 3 years before I applied for the MAC role, I don't think I really truly understood or really had heard much about the MAC. And it was probably this sort of 3 months before the interview that I really had to just gel up on it. But anyway, so the Medical Advisory Committee holds about 10 meetings a year. So we meet every month and we have 2 months off in the summer. And it's in accordance with the Public Hospitals Act. So we have to report to the board such things as the professional staff applications for appointments and reappointments. So every month or every 2 months, I provide the credentials report, which is what the privileges and the appointments come under. And we also have to report any bylaws that are in respect to the professional staff. Also, if there's any dismissals or suspensions or restrictions of privileges for members of the professional staff. We report the quality of care that's provided in the hospital, and also any clinical and general rules or policies with respect to the work we do. So what does the MAC actually do, and what's its role? I mean, we're supervising the practice of medicine and the delivery of care by all of the professional staff in the hospital. And the members, the MAC has many committees under it, and we appoint the medical staff that sit on these committees. Some examples are the Pharmacy and Therapeutics Committee, there's the Death Review Committee, and so forth. And those reports of each of the subcommittees will come to the MAC every month. We also have to advise the board on anything that has been referred to the MAC. So if we have, say, a special MAC because, for example, if there was a violation of a policy, such as the vaccination policy, and we had to have an individual come in front of the MAC, then that will then be reported to the board. We also have to monitor for quality. So I sit on the Quality of Care Committee that Dr. Stacey chairs, and then also the Death Review Committee. So next slide, thank you. So who's on the committee? So I'm the chair, and I'm a member, has to be a member of the professional staff. Each chief of the department, the 18 departments, also sits on it. We also have the president, vice president, and the secretary and treasurer of the MSA. And then there's also members from the hospital administration and executive leadership team. The voting members are the chiefs of the departments, the members from the MSA and obviously myself. Next slide, please. So that's an overview of the MAC. What are the current topics that have been discussed recently? And I know Dr. Stacey and Ron Kaiser have touched on a few of these. So we've been discussing, the mandatory vaccination policy that had to go through MAC and be passed by the members. We had a unanimous vote for that. There's also this any newly appointed positions, newly created positions, such as the senior medical director of EDI. So there'd be a discussion about that, and then a vote to pass and approve this new role. We have an update every month from the Odyssey team, from Barry Lum and Rob Lloyd. And one thing that I would really extend to all the physicians on this meeting is that if you can get involved, and as Rob mentioned, if you can spread the word about Odyssey and bringing the excitement of this new and really the biggest change that's going to happen in HHS in most of our careers, that's going to be incredibly vital, because change is going to be difficult. But if the physicians are seen to be completely on board and promoting the training on how to use Odyssey, and we've got lots of super users I know who've already started to get trained to help the members of their team, I think that's just going to help the change be palatable, and it'll just roll out to the departments and the wards. One thing that Dr. Stacey and the Medical Affairs Department have really undertaken and transformed is the way that the physician leadership positions are defined and the term lengths. Something that I really want to improve is the engagement of physicians in all aspects of hospital life. There are many committees, and I think people sometimes are reluctant to put names forward to be on these committees, and it may be because they feel that certain people have been in that role for many years and there's no end date to their terms. Certainly some physician leadership positions in the past, there was no real clear succession planning, but now the roles are delineated. They will be for a defined length of time. There might be one renewal for that post, but we want turnover, we want fresh blood. And I think that if we can have more engagement, and if you know of people who are interested in being hospital leaders, or if you yourself are interested, it would be great if you could put your names forward for things, and when new posts are advertised, if you'd really consider applying. At the moment, it's difficult to do succession planning. We're not seeing each other in person as much, but I would hope that we'd have a constant stream of people who are interested in leadership, learning about leadership, and then applying for these posts, so that it's seamless. Where we'll always have a great pool of people who are motivated and enthusiastic on taking on some of these roles. So I think I'll leave it at that, Deepak, because I know we're running behind, and I'll take questions at the end. Thank you.
Thank you, Dr. Halder. So that's really encouraging to know that that we are getting things in a position where more people can see opportunities to help, to step up and to do something when they really want to engage. That's so exciting. And I'm glad that you were able to bring what the MSC does to us now. As you said, I as well, for many years, had no idea what the MSC was, or what it does, or what it meant, or how it made a difference. But clearly, as in my role recently, I've noted how important it is, and how the people who are on the MSC are dedicated to making those changes and making these things happen in a very good way for our organization to move forward. So thank you so much for that. I think the next person on our list to speak next is Dr. Barry Lum, who is going to tell us a bit about our beloved upcoming EPIC.
Thanks very much, Deepak. Thanks for the opportunity to give an update, and just thanks for all the previous speakers who've endorsed the importance of Odyssey, and the plea to please get involved and stay enthusiastic as we move forward. If you go to the next slide and go forward one. So what I'm just going to do is a very brief update of where we're at. As of today, we're 197 days from go live. We are absolutely committed at this point to the June 4th, 2022 date. And obviously, we have a very long road ahead of us, but it's getting closer and closer, and we're all starting to feel the real enthusiasm. The stage of the project that we're at now is important, because we have completed what's called the build phase, where we are establishing the HHS version of the EPIC Canadian Foundation system. And that work is over 90% complete. Most of the testing of that work is now complete. And that means that we're moving now from build and test to execution. And the work now from today on to June 4 is about how we prepare the organization to be ready for this event and to move forward, and so that we're comfortable that everybody is ready, and in particular that people are properly trained. The key here, though, is that given that this build work has now been completed, the opportunity for further change in the build is really very minimal at this point, unless we identify significant clinical concerns or risks that would require us to pivot and go back. And so that does not mean that further changes won't happen to the system. They absolutely will, but that will now move to the stabilization and optimization phase, unless, as I said, something really important finds its way. So if you go to a session, you say, I'm not so sure I'm really giggly about how that was done, unless it's a big issue, we're going to have to readdress it after we flip the switch on June the 4th. We know beyond the shadow of a doubt that training is the most important success factor for physicians in the system. And so we are very busy now establishing all of the training tracks for our physicians within the system. There are actually 42 different tracks of training, and everybody who works at HHS, physician and others, will need to complete training in order to be able to take part and work in our system. The registration for that training will begin within about a month. I know that sounds like a long way off if you think that it's not really going to be formal training until April or May. But we have to register 12,000 people to the training tracks. We need to establish that we've got them on the right training track, and then individuals will need to complete a short e-learning exercise before they actually come to training. So you're going to hear more about this very soon, and we're going to start signing people up for their training events. You do need to complete the registration, and then following that, the online introduction, followed by the in-class training, followed then by an assessment of your skills to confirm that you're ready to go. And finally, there will be something called the user settings phase, where you will give you the opportunity to personalize the system for your own use and to make it the best it can possibly be. Most of you, or many of you, will be using admin assistants to support your clinical activities, and we've been very busy making sure that we establish all of the activities that your medical secretary can undertake on your behalf as part of your clinical practice. That has now been presented and approved by the MAC, and we will be establishing a formal training program for all of the admin assistants, and you'll be hearing more about that. One of your assistants will need to go off for most of a day to be properly trained to support your clinical practice at Go Live. And the last point, thank you, is this issue of cutover. Just very briefly, if you think about it, all activities and all information related to ongoing patient care in Meditech will need to find its way into Epic, so that at 4:01 on June the 4th, we can continue to care for our patients. So there's a very big effort needed to complete the conversion of all of the information in Meditech and what we call cut over all of the patients who are active in the system at 3:58 on June the 4th to the go live on 4:01 on June the 4th. So you'll be hearing more about that. And that's it for tonight. Deepak, I'm more than happy to take questions. Thanks for the opportunity.
Well, Barry, that's a great and very important update for us. Thank you so much. There's so much to do. I look forward to our members, really engaging as they move forward and helping those who they work with to move forward with them. Right? It's going to be a team effort. As you know, we've started off our blog to say this is how you can maybe just get a couple of things ready, thinking about how your current practice works so that you can decide how you will work new in Epic. And so please take a look at the blog, and we'll start to see if we can get you a bit oriented so that we can all move forward together. And then I want to introduce you to somebody who I've known for these 25 or 30 years now. His name is Ali Prabhutani. Dr. Ali Prabhutani is an endocrinologist at HHS. and he is here to speak to you about global health. And I remember when Ali was a medical student with me, and he was one of the most enthusiastic people, happy, helpful people I've ever met, and he continues to be. He has agreed to come and speak to us a little bit about what he's doing right now as a member of HHS who's reaching outside these walls to help people on a global scale. And I hope his message resonates with you, and I hope that you can join him in his efforts. So Ali, perhaps if you're here, it looks like you can take it away.
Thanks so much, Deepak. Just wanted to start off by saying that I feel like I have a pheochromocytoma whenever I hear Epic or Odyssey. No offense to you, Barry, but I know hopefully we will learn with time. I also wanted to thank Deepak and the MSA exec for the wonderful work they're doing, and it's so important, and I've learned a lot today also. So maybe can I share my screen? Yeah, there we go.
Your slides are up, Ali.
Okay, I'm just gonna, I might have made a change, Deepak. Okay, that's fine. Is that okay if I use this? Great. So what I'm going to try to do today is, in a short period of time, try to excite all of you and define what global health is and how all of us can make a difference to people who really need it beyond Canada and the Western world. So this is the definition of global health in a nutshell, based on the WHO. Global health is the health of populations in a global context. It has been defined as the area of study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. And I wanted to repeat that, in achieving equity in health of all people worldwide. So who's involved with this kind of work? It's just not me. We have a great team of people, and nothing happens in silo. So I wear two hats, the McMaster hat and Aga Khan Health Services hat. And we have a number of people from multiple disciplines and non-MD centric approach also. So it's just not about physicians, it goes beyond that. Just wanted to say a one-liner about what Aga Khan Health Board and Aga Khan Health Services is. This is a development network which provides international healthcare across the world, globally, in particular in low-income and low-middle-income countries. And over 200 healthcare facilities are actually facilitated by this organization, mainly in, as I mentioned, the low-income countries. Where is most of our work? Both McMaster and AKHS. I bolded where most of our work is right now based on needs and where our presence is, virtually and pre-pandemic on-site. Uganda, as you may be aware, we have a strong collaboration in Uganda, especially with McMaster, but with AKHS, we have a lot of collaboration in Afghanistan. Even during the political situation right now, we're continuing to support and collaborate and provide educational and clinical service. Syria, and to a lesser extent, but still importantly, Tajikistan, East Africa, in particular, Tanzania, Kenya, Guyana, and Namibia. So what are we doing? I'm going to start off with probably one of the most important things is knowledge translation, which comes in the form of education. We're doing a lot of virtual teaching based on needs. So what do they want? And this is not just medicine. We have delivering educational sessions by experts from McMaster and beyond McMaster in areas of neurosurgery, internal medicine, pediatrics, OB-GYN, et cetera, from a variety of people. Before the pandemic, we were doing a faculty exchange with an elective where we would send residents and medical students, and even faculty would go there and come here to provide bi-directional exchanges and education and building bridges. This is often based on CanMed's principles, which has been proven to be effective and standardized quite globally. In fact, a lot of other institutions are using these CanMed's frameworks. We have a formal evaluation tool for our electives and our educational sessions. Even with our CMEs we're doing, we get feedback so we can make changes based on feedback on the ground at the host country. And again, just to reiterate, this is a multidisciplinary interaction, just not MDs. It goes beyond internal medicine and beyond physicians. So an example is if we do an ICU session, we have respiratory therapists there, we might have an ICU nurse there, a pharmacist, and so on. We're trying to engage all the key players to maximize educational services and even translation. So why can we do this now? So if you looked at this about 20 years ago, this would all be slow speed, but even these low-income countries, you'd be surprised. They have very, very active internet, which is very, very rapid. Contrary to popular thought, it's very successful and efficient, and rarely do we get any glitches in terms of breakdown of the generator or so on, regardless whether it's Afghanistan or Uganda or any other country that we provide collaboration with. Before the pandemic, we were providing on-site clinical supervision for the residents and for faculty who wanted that kind of assistance, but now we're doing a lot of WhatsApp group expert service. So people or MDs or healthcare providers, and for example, Afghanistan being probably the biggest collaborative group here, We have an expert group on WhatsApp with different services, internal medicine, ICU, OB-GYN, and if they have a clinical question, they would run it through WhatsApp to one of our experts here who's tied up, and there'd be ongoing communication to provide better care. And basically, if it doesn't surmount to if it doesn't answer the question, they'll pick up the phone and use WhatsApp as a free service to go into further details to provide better patient care on the ground in the host site. We're also providing subspecialty training, in particular in Uganda. They actually, the residents come here, as you may know, and they actually get a diploma so they can go back to their home host country and build capacity, again, in a multidisciplinary manner. Another thing we're doing outside of medical particular is a fundraising. We do it in two ways. We have an internal medicine gala that we do an auction and we raise lots of funds, and all of it goes, generally speaking, to Uganda, the medical system, which is all accountable for. And it goes to things like medical equipment, resident training, faculty development. We even support a primary school, which is a public school where we support things like putting up cabinets, for example. And Barry's seen some of this stuff when he came with us a few years back, Barry Lum. And we also build toilets, which is, for us, we think it's really simple, but this actually has primary care preventative strategies in terms of sanitation and so on. Our most recent success has been, we've raised about more than $750,000 worth of PPEs and medical equipment from across Canada, and thankfully also to HHS and St. Joe's and lots of other donors and friends and family. And right now we're tracking this. It's actually very close to the Middle East and it's en route to Mombasa, and eventually it'll get to Kampala and Mulago Hospital, where it'll be distributed by some key players who we have a very strong collaboration with. We've also developed some scholarships based on merit, where we identify some criteria, but we let the people on the ground, the medical people on the ground, decide who's going to get it. In particular, it's been residents and medical students based on merit, and partly based on like a bursarial type support in terms of financial need. So what else have we been doing? I'm not going to spend a lot of time on this. We do a little bit of research, collaborative small projects if they're feasible. We also have a cross-appointment memorandum of agreement with, in particular, with Uganda, where many of us who do a lot of work in Uganda, and many of them who do a lot of work in Canada, at McMaster in particular, will get a cross-appointment, which is a really positive thing. And one of the other things we've recently developed is that I've been involved with is a healthcare delivery document for refugees and immigrants, in particular relevant to Afghanistan, which hopefully be used across Canada. So that took a lot of time, but it was very, very enjoyable. I learned a lot about immigration health and refugee health and so on. So that's something that we're also delivering very shortly. We've shared a lot of resources. We were able to secure up-to-date free in Uganda and at a nominal price in Syria and Afghanistan. Yorman Yashki, who's the editor of MTM, the McMaster Textbook of Medicine, was able to provide free complimentary subscription to all of the low-income countries we deal with, and even all our McMaster review courses, whether it's internal medicine or endocrine, we've been able to provide free complimentary registration to all the low-income country healthcare providers. And something that we're working on, which is in process right now, is something about quality improvement. We've had a lot of feedback in terms of qualitative impact, but we're working on metrics and quantitative indicators, and looking at KPIs, which are key performance indicators, to look at more of an impact analysis and what kind of actual quantitative impact that we're making in terms of healthcare delivery and things like length of stay and death and surgical outcomes and so on. These are some testimonials that we received, and this is a short number. We've received several testimonials showing us that I think we are making a difference, although it's qualitative, but we're getting a lot of feedback, and they want more. They want to engage and collaborate more with these educational sessions and expert group and resources and so on. So it's something that made us tick a little bit, made us feel that we are hopefully making a difference to those really who need this type of support and collaboration. We're working as a team rather than to them. We're working with them rather than to them. And that's really important to remember when you're dealing with different cultures. There are some challenges, of course, differences in culture, which we train all our providers to be engaged in and be aware of. There is a language barrier. Often it's minimal because most of the people do speak English, especially at the level of the audience that we're dealing with. There's some time zone differences. So most of the work that I'm doing is often at 1 in the morning or 6 in the morning because of the time difference. But it's because of the passion and the fun that we're doing this, it doesn't really make a difference. And a lot of people don't mind doing this once in a while, especially if it's making a difference. I've already talked about quantitative indicators we're looking at, and we have a long-term strategy. And I really wanted to stress that nothing has happened in silo. This is because of a great partnership with the friends and the colleagues that I have in Canada and across the world, and a lot of support that we've had from all these people. So overall, this is really important. At the end of the day, the most important thing is that we build capacity. It's got to be sustainable in a culturally sensitive manner in a multi-D format, which I've already discussed. And we got to really pay attention to local resources, because we may have something here, but they may not have there. And that'd be kind of an insult if we ask them to start using, start doing MRIs on every patient with a headache. It wouldn't be feasible. It wouldn't make sense. And we always base it on needs. And the aim is for best practice and to avoid medical terrorism. And at the end of the day, to really, really enhance the definition of global health, which is equity for all. So how can you help? You can all help. Education is really easy. CMEs and it's interactive. It's all virtual right now. We organize everything for you. We provide the links and so on. And there's a lot of expertise in this group today. So please consider this. And even if you have an interest in an expert group, joining an expert group, we can actually use you there. I've spent lots of time with the CMPA, and there's a code 8 that you may have heard of. It's a humanitarian code. So there's no liability as long as we provide care that's in our expertise and in our competency. So we're fully covered by CMPA. It's free. You just got to register. It takes 2 minutes, and then it's actually autopilot research. There is also a play there. And of course, an ask from MSA is if there's funds, we would love to have funds for things like fundraising and for scholarships, which goes a long way for our residents and our learners across the world in terms of merit and also need. If anyone speaks different languages, in particular Farsi or Dari or Arabic or even Luganda, this would go a long way to help with some of these sessions. And if you know of any medical resources that can be supplied on a complimentary basis or reduced level, that's again another added benefit for the groups that we work with. So hopefully we'll get to go on the site soon. This is Uganda. Just a few years ago, we're doing some ward rounds. I got permission and consent to show this picture with the patient and with the residents who are so keen and passionate and thirsty for knowledge. Wanted to leave the last couple of slides with something that's so important to show that you can all make a difference. This is an African proverb. If you think you're too small to make a difference, you haven't spent a night with an African mosquito. There's so many people to thank. I just wanted to show a couple of pictures, but a few people that I did want to mention today who are part of our MSA, people like Sanjay Sharma, who's been, I ask him one thing and he comes out right away to do sessions and helps us out. Catherine Place never says no to anything. Wes has always been supportive of our work in Uganda. And of course, Barry Lam, who's been supportive throughout the years with the work, myself being an internist and endocrinologist. So I wanted to at least thank them because they're here on the call today. But there's so many people that I can thank. It would take another hour to thank. So thank you very much. That's all I'd like to say and share that from global health point of view that we're so lucky to be part of.
Ani, thank you so much for that presentation. It's inspiring. And I think this is the second time I've seen it, but I always feel so so warm to know that you and others here are doing so much for others elsewhere who need your help. So let me echo your call to our membership to try to be up at 1 o'clock in the morning, maybe sometime next week or something, or whatever you like to do. It's something that you're passionate about anyhow. You're here doing what you're doing because you love it. And now you can love it more by doing it with somebody who really needs your help. So please help, get to the website, see the link, get to Ali's site, talk to Ali. He's quite wide open, and I'm sure you've seen, like I have seen, that he's the most enthusiastic and happy and go-getting individual you'll work with for a long time. Please do help this, and let's all make a difference together. I think that's the main part of the presentations we have for you today. We have a few minutes left. We have 20 minutes left, and I'd like to see if we can open up the floor now to the members who might want to say something or raise their hands and have a question. I do see Dr. Susan Wasserman has her hand up. Maybe we could unmute her. Would that be possible, Evelina? So we can do that. And I think, Susan, you may have to unmute yourself there so you can ask your question if you have your hand up.
Sorry about that, Deepak. I didn't actually have my hand up, but thanks.
Well, okay. Maybe we can go to the chat.
Yeah,
No?
Deepak, we have some questions and some comments. One of them was a comment just saying that Epic will be great and can't wait till it hits the ground running. So I think everyone can echo that sentiment. And then Alicia Fox-Rovershot also wanted to mention that we're entitled to get Section 3 main port credits or CCFP for all physicians as part of their EPIC training. So, maybe remember to log that in your main port as part of your training and education. So you can get credits for that, learning the new system that will be across the HHS. And then Thomas Van Helder asked, do we know how strong EPIC is against ransom or cyber attacks? Maybe that's a question for Barry.
Yeah, so EPIC will be hosted for HHS on our own servers. So we are therefore, in terms of EPIC vulnerability, it relates to HHS vulnerability, and you'll probably all be aware that subsequent to the attack that we had a few years ago, the HHS security has been extremely enhanced, and I would say as good as it can be in this environment.
That's nice to know. Any other questions about EPIC? I know there's tons of stuff that come up as we see each other in the hallways now and then, but maybe you can bring your questions to this forum and we can all learn something from what you have to say or ask.
Deepak, it's Allison. Just to follow up, not only will we have section 3s for everybody who's completing their EPIC training, we're also hoping to have section 3 simulation for those physicians who take on the role of training their colleagues. So there'll be double bonus points if you've signed up to be a train the trainer.
That sounds great. Thank you, Allison. The section 3 credits are the ones that are hardest to find, as you know, when you go to your MOCOM thing. The section 3 ones are the ones that are hardest to find evidence of, and this is a great way to do it. It's considered part of practice review. You're reviewing your practice to see what you do now and how you change your practice to a different way, and that counts in a significant way to you being a responsible physician learner for tomorrow. So you get 3 hours in MOCOM for every 1 hour you spent working on improving your EPIC. Do we have questions for Michael Stacy or Sharon Pearson? Anything for Bill Rostevsky or Thomas Van Helder? Dr. Smita Halder? Okay, so perhaps it's time to thank our speakers. And it looks like we're a bit early, but we may be able to give you back the gift of time, as we say. So first of all, let me take the opportunity to thank Sharon Pearsons and Michael Stacy for coming. Rob, who had to go on to a different meeting, so he's not here anymore. But also Dr. Smita Halder, who spent some time trying to educate us about what the MSA is about. And Barry Lum, who has brought to us I guess, a bit of the urgency of EPIC coming up, but still that excitement that we are going to have a much better system very soon, and it's going to knock your socks off. Will, thank you for bringing in line our financials, and Thomas for opening our eyes to what our celebrations are, because that's what our awards really do, is celebrate those physicians in our midst, as well as others, who do a really great job and who we look up to and count as great colleagues. And finally, Ali, love the presentation again. I love what you're doing. I live vicariously through your efforts, as you know. So keep up the good work. And I look forward to you having droves of HHS physicians joining you as you do this good work. So thank you so much. I'd like to say that this is the first time we're holding our GBM in such a way where I think we're looking forward to so many things, like, many of the things Rob talked about in the future, and the opportunity for us to participate in such a good way. Dr. Halder talked about improving our ability to lead and to participate. Dr. Stacy talked about many different things where we can partner with the hospital to get our work done, to look at how we work with those who have been our partners during COVID, for instance, and continuing that relationship we're building so that we can move forward together with trust. In terms of things coming up, I'd like to say that in future events, we have our virtual awards and charitable donation presentation in January. We're looking for you to nominate the people for those awards. And then in April 21st, we expect hopefully an in-person meeting for our spring meeting in April 21st. We haven't chosen a location yet, but we'll have to still see what the lay of the land is, so we can make that a great event. And again, our MSA annual dinner and awards in June, on June 23rd. So please pencil these things into your calendar now so that you can attend and help us, and we can work together. We have a few minutes left in case any other questions have come up. Please let us know. If not, thank you very much from all of us at the MSA Exec, and to those of you who have spoken today and who've enlightened us, please carry along with us your thanks as well. I hope you all have a great night, and that we're all looking forward to our big epic. Thanks again.